So today we are going to talk about antiretroviral drugs. So have you treated HIV in internal medicine?
Yes, Doc.
Yes, Doc.
Okay, then that makes it easier. So you know about the antiretroviral drugs.
Yes, Sam.
Are we going to say no?
No,
Okay.
Yes,
Sam,
yes.
Sam, yes.
So since you know, I'm going to be asking questions now. So what is the recommended regimen for the treatment of HIV? First line.
Doc, that's the first question.
What's the combination like? The treatment. You want to start, so you diagnose the patient with HIV. What combination? How do you go about it?
Tenofovir plus lamivudine plus dolutegravir.
Dolutegravir, yes.
Yes.
Okay, you. So I think my work is easier.
Hey.
We're going to talk about antiretroviral drugs. We are going to talk about how they work, how they are absorbed, how they are metabolized, some of their drug reactions. Okay, so basically, the reason I asked that question is that I want to bring home the fact that monotherapy of antiretrovirals isn't recommended for treatment of HIV infection. So you won't go and say, okay, I've diagnosed HIV. Tenofovir is an HIV drug, so I'm just writing a prescription of tenofovir for the patient to go. No. For best results, you need a combination of antiretroviral agents. And there are several classes. So we are going to look at all the classes. We have nucleoside analog reverse transcriptase. We have non-nucleoside and reverse transcriptase inhibitors. We have nucleotide reverse transcriptase inhibitors. Hey, mute your mic, so mute your mic. Recently, we have integrase inhibitors, and then we also have fusion inhibitors. So the fusion, it is not included in this lecture. They are very new drugs which have recently been brought on board. The fusion inhibitors inhibit the entry of the virus into the cell. So before you understand the action of the antiretrovirals, you have to look at the cycle of the HIV and the microbiology. So please go back and revise that. Look at how the virus enters the cell. What does it identify on the CD4 cells? How does it bind? How does it enter? When it enters the cell, what happens? So basically, when the virus identifies the CXR5 or CCR3 on the surface of the CD4 cells, it binds to it, to these two receptors, enters the cell. When it enters the cell, by the action of reverse transcriptase, it transcribes its RNA into DNA and incorporates it into the cell's replication mechanism and further replicates. Now, when it replicates and produces proteins, the protease inhibitors, the protease enzyme cleaves or cuts up the protein that has been produced into sizable portions for making of the viral envelope and other protein components of the virus. And then it assembles and forms a new virus. And that is how the HIV virus replicates in the human body. So the various medications target the various phases of the HIV infection and disable the HIV virus replication mechanism so that the virus will not multiply in the body. So the first group of drugs is the nucleoside analog reverse transcriptase inhibitors. So what this is the nucleosides. are one of the key components in DNA synthesis. And so this is how it works. What it does is it's used to treat patients with advanced HIV infection. And zidovudine is in this class, lamivudine is in this class, abacavir is in this class. These are the common antiretrovirals that are available in Ghana. But we also have diadenosine, emtricitabine, and then stavudine. And zidovudine was the first drug to receive FDA approval for treatment of AIDS and AIDS-related complex. A very old drug, but it's still very useful. So when we look at pharmacokinetics, abacavir is rapidly and extensively absorbed after oral administration. It is well distributed in the extravascular space, binds about 50% of the plasma proteins. It is metabolized in the liver, excreted in urine, some in urine and some in the stool. When you take lamivudine and stavudine, they are rapidly absorbed after oral administration and excreted by the kidneys. And the same thing follows for emtricitabine. There's something peculiar about diadenosine. It is rapidly degraded by the gastric acid in the stomach. So it has a buffer, a buffering drug coating it so that it doesn't disintegrate in the gastric acid. And it is absorbed and excreted in the urine. Zidovudine is well tolerated from the GI, so it's taken orally. It's metabolized by the liver, excreted by the kidneys. So you know that a lot of the medications are metabolized by the liver and excreted by the kidney. And therefore, if a patient has kidney problems or liver problems, you may need to adjust the dosage. Otherwise, you would have dangerous levels in the body as a result of inability of the liver to metabolize and the inability of the kidney excrete the medication. And that means that the medication will stay in the body and become toxic. Looking at the pharmacodynamics, a lot of the medication, the nucleoside reverse transcriptase inhibitors, they undergo conversion to the active metabolite. So if you take a look at each of them, they are converted in the body to an active form. And it's the active form that inhibits the reverse transcriptase. So generally, as a group, what they do is that they inhibit reverse transcriptase, which is supposed to cause the transcription, the conversion of the viral RNA into DNA for incorporation into the cell's cellular division mechanism so that the virus can replicate. And so once it attacks this mechanism, the viral So for all the classes, you see that there's an active metabolite which prevents the viral DNA from replicating. Okay. So therapeutically, there is oral zidovudine and there's IV. The IV is used for patients who are hospitalized, obviously can't take oral medication, to prevent transmission of mother to child transmission of HIV, and for patients with dementia. And if for one reason or the other the patient cannot take zidovudine, diadenosine can be given as an alternative. There is this combination medication, and like I said previously, the antiretrovirals are not given as monotherapy. So there's Combivir, which is a combination of lamivudine and zidovudine. And then there's also Trizivir, which is 3 nucleoside reverse transcriptase inhibitors, Abacavir, lamivudine, and zidovudine. When we look at drug interactions, there are a lot of them. We realize that you can give lamivudine as abacavir and zidovudine together. However, you can't give stavudine and zidovudine together because stavudine inhibits phosphorylation, and so you cannot give them together. Then there is this lactic acidosis and severe hepatomegaly, which can occur in patients who are taking the NRTIs alone. So maybe you are taking Abacavir, zidovudin, lamivudine together. You can have severe lactic acidosis and hepatomegaly, or you're taking them with tenofovir. And it was found that majority of these patients were obese patients who had been on these 3 medications for a long time. So that's why it's important that when the patient is going to be started on antiretrovirals, we do kidney function tests, we do liver function tests. And then also regularly, whilst they are on the antiretroviral therapy, we do liver function tests as well as kidney function tests, maybe yearly or every 6 months. Now, when you are taking zidovudin with a medication that causes kidney toxicity, the risk is higher. So medications like flucytosine, vincristine, vinblastine, doxorubicin, these are the anti-cancer medications or the chemotherapeutic agent. You have to be careful. Then patients on other antiviral medications like ganciclovir, you also have to be cautious. And the patients on dapsone, which is used for the treatment of leprosy, you have to exercise with regard to kidney toxicity. Then also, when you take some medications with zidovudin, it increases the potential for these medications to become toxic. So medications like aspirin and acetaminophen, understandably because they have an effect on the liver. And zidovudin also has a similar effect, and so they can potentiate this negative effect. And then when zidovudin is taken with acyclovir, you can have profound lethargy and drowsiness. Bear in mind that acyclovir is used to treat herpes labialis, herpes simplex. And these infections are commonly seen in immunocompromised patients, such as patients with HIV. So whenever you are given a combination of zidovudin and acyclovir, you have to look out for this. Or you can decide to give another antiviral agent if the patient is already on zidovudin. Okay. And when you are given certain medications like fluoroquinolones and tetracyclines, you have to be careful when you are giving didanosine because it can reduce the absorption of the fluoroquinolones, for example, ciprofloxacin or tetracycline. And then it's also very important for us to take note of the interaction of abacavir with alcohol. So when you are taking, if the patient is on abacavir and they take alcohol, the levels of abacavir increase with alcohol consumption. What this means is that the patients can reach toxic levels of abacavir just by consuming alcohol. So you need to talk to the patients about this, especially seeing that somebody with HIV may have other social problems and they may be prone to alcohol abuse as a result of these social problems. So it's very important when you are starting patients on antiretrovirals to talk about all these drug interactions. Then looking at adverse reactions, the commonest one that is always at the top of the list is blood-related reactions when it comes to zidovudin. So commonly, we say that if the patient's HB is low and you are going to start antiretroviral, zidovudin will not be a good choice. So you can do something else. Maybe you can do lamivudin or the other medications. Once the patient has anemia, zidovudin is out. So blood-related reactions, they can have headache and dizziness, muscle pain, fever, and rash. They can also have nausea, vomiting, and abdominal pain. These ones, you can just reassure the patient that, oh, these are parts of the medication, and as the body gets used to it. So didanosine is associated with the GI problems as well as stomatitis and unusual loss of taste or unusual taste in the mouth. dry mouth, and pancreatitis. So you notice that I've separated the adverse reactions. You have GI adverse reactions stated first. Then you have CNS adverse reactions, so headache, peripheral neuropathy, and dizziness. Then they can also have integumentary or musculoskeletal reactions like muscle weakness, a rash, itching, muscle pain, and then hair loss. Then abacavir can produce potentially fatal hypersensitivity reactions. So when you notice that a patient on abacavir develops a very bad rash, it may be time to stop the medication. Okay, so we go to the non-nucleoside reverse transcriptase inhibitors. So these medications inhibit reverse transcriptase, but they are not nucleosides. So these ones are called NNRTIs for short, and they are also used in combination. I cannot overemphasize the need for combination therapy. So actually, antiretroviral medications are not found in the pharmacy. You can't just walk into a pharmacy and say that I'm buying lamivudine or I'm buying zidovudine. No, it's not available like that because they need to be given as a combination. And so when this is not done and patients abuse them, there's a high risk of developing resistance. So okay, yes. So they bind the reverse transcriptase enzyme and prevent it from replicating. Basically, that's what it does. And they are used in combination, like I said. And typically, nevirapine is specifically given for patients who have a low CD4 count and a low immune status. So here too, there are lots of drug interactions. So when you give them with the protease inhibitors and hormonal contraceptives, the nevirapine will decrease the activity of these because it stimulates the cytochrome P450 system, which metabolizes the medications and makes them ineffective. So if a patient is on nevirapine and taking the oral contraceptive, they may need to use another method of contraception as a backup. Then when patients take warfarin, benzodiazepines, and clarithromycin, their levels may also increase, leading to increased risk of toxicity. Also, when you give the lavagine with indinavir, which is a protease inhibitor, it also increases the metabolism of the indinavir, and therefore you need to, it increases the concentration, so you may need to decrease the dosage so that you don't run into a risk of toxicity. Nevirapine can be associated with a rash. So if the rash continues, you have to discontinue the drug. This is similar to the rash that you find it with abacavir. So as a group, some of the side effects include headache, dizziness, nausea, vomiting, rash, and diarrhea. Okay, so nucleotide. So the first one is nucleoside. Now this is nucleotide analog reverse transcriptase inhibitors. And the only one we have is tenofovir. And it is used as a combination with the other medications. And one important thing about tenofovir is the fact that it is absorbed better after a high-fat meal. So this is very, very key and very important when you are and prescribing it to the patient. So patients with anorexia who is not eating well, you have to hammer on this so that you have better absorption. And this metabolism is not mediated by the P450 liver enzyme. It's excreted by the kidneys. And it competes with substrate for DNA replication. It's incorporated in the DNA chain, and then it stops the HIV viral replication. It is used as a combination medication with other antiretroviral medications. And when you take tenofovir, medications that are eliminated through the kidneys may also be affected if you take them concurrently. And medication like diadenosine levels will increase when you are taking it with tenofovir. And then you can have this potentially fatal lactic acidosis and severe hepatomegaly when you take tenofovir. And a lot of these patients were obese and they were on the nucleoside reverse transcriptase inhibitors for a very long time. If a patient has pre-existing liver disease, you should be cautious when you are starting tenofovir. Or you can even decide not to do tenofovir and do something else. But as you are monitoring the patient on antiretroviral, if you suspect or have reason to suspect hepatotoxicity, maybe patient has been fine, liver function has been fine, and then as you're doing your routine liver function test, you realize that the liver function is, the enzymes are all deranged, then you have to suspend treatment with tenofovir. So some of the adverse reactions, nausea, vomiting, diarrhea, anorexia is normal, but the severe hepatomegaly and lactic acidosis is very important to take note of. So the last group are the protease inhibitors. So what the protease inhibitors does is that when the viral particles during the replication, protein synthesis, we all know that you have the DNA template, then a daughter DNA is formed, then the messenger RNA will come in with the codons, and there will be transcription and translation, and then the protein will be produced. So at the point that the protein is produced as a large molecule. So the protease is an enzyme that cleaves the protein into sizable chunks that can be used to produce the viral envelope or the reverse transcriptase enzymes or other enzymes or other proteins that form the HIV molecule. So what the protease inhibitors do is that they inhibit the action of the protein. So the protein is formed, but it cannot be broken down. And so the viral envelope cannot be assembled, or the viral particle cannot be assembled. And this effectively stops the production of new viral particles. So when we take the protease inhibitors as a class, they act against HIV enzyme protease, a larger viral precursor protein, into the active smaller enzymes that the HIV virus needs to be fully mature. And this leads to an immature non-infectious cell. So the drugs in this group, you see that the name ends with VIR. So lopinavir, ritonavir, indinavir, those are common in Ghana. And then you have the rest as shown. So lopinavir is extensively metabolized by the liver, the cytochrome P450 system. And ritonavir acts as an inhibitor of lopinavir. And so its antiviral activity is due to the action of lopinavir. The others are shown, but generally, as a class, you realize that they are metabolized by the liver and excreted by the kidney. Some are excreted in the stool. They are well absorbed through the GI. Okay, so we just talked about each of them. So by way of pharmacotherapeutics, they are used as a combination. It's important to take note of their drug interactions. So, for example, if you're taking it with anti-seizure medications, their action may be reduced. So, examples are phenobarb, phenytoin, and carbamazepine. And then, if you're taking with any of these medications, the effects may be increased. So, take note of the anti-malarial, erythromycin, and then the corticosteroid. So if a patient is on any of these medications, the activity of these medications may be increased if they are on ritonavir. The metabolism of the benzodiazepines may also be inhibited. And if you're taking diadenosine, it decreases the absorption of indinavir phosphate. So you should take it at least 1 hour apart. All these are instructions that are usually given when the patient is started on the medication. So these are drug interactions that are important to take note of as a class. This is a very important thing that I thought I should mention. So when the patient is on sildenafil citrate, commonly called Viagra, and you're taking protease inhibitors as well, what can happen is that the levels of the sildenafil will be increased, meaning that the adverse reactions that are associated with the sildenafil would be potentiated. So adverse reactions like hypotension, priapism, vision changes. So it's very important to warn the patient about this. So this can be circumvented by decreasing the dose of sildenafil that the patient will take. And then also certain medications like HNG-CoA reductase inhibitors, these are the statins, medications that are used to treat high cholesterol. They shouldn't be given with atazanavir. And then medications that prolong the PR interval on ECG, like calcium channel blockers. Example, nevirapine, diltiazem. You shouldn't give them with atazanavir. And if you are giving it with medications that cause sedation, like midazolam, there might be increased sedation or respiratory depression. So these are very important. And when you are taking some of these medications with sulfonylureas, which are used for hypoglycemia in treatment of diabetes, it can cause, it can further decrease the sugar level and the patient might go into hypoglycemia. So it's important for us to take note of this. These are some common adverse reactions when you are taking the protease inhibitors. It's very important to take note of the depression, the deep vein thrombosis. And then also hypercholesterolemia because of the effects that I mentioned with the statins or the medications that are used to treat high cholesterol levels. Okay. These are other. Any questions, please? Are there any questions? You've sort of been introduced to this in internal medicine. Isaac, do you have a question? I can see that your hand is up. Or hello?
Hello, Doc.
Yes, I can see your hand is up. Do you have a question?
No, I just press my hand just pressed on the on the phone, so
okay.
I don't have.
All right.
I have a question.
Yes, please go on.
Please, my question is, Yes, my question is, if you have a new diagnosed client,
Mhm.
but the medication that you've given, the patient reacted to it, but it took just a week, can you just change, or you have to wait for that 3 months or 1 month before you change, or you can change just within after the 1
It
week?
depends on the reaction. So, for example, if you have hepatotoxicity such that the patient's liver function is very deranged, or patient has severe jaundice or Stevens-Johnson's reaction, which is life-threatening, then you have to change it. But if it's a minor reaction, like maybe diarrhea and vomiting, nausea, you can wait and see how the patient gets used to it. So it depends. Are you okay?
Yes, Doc.
My question, madam.
Doc, I have a question.
Daniel.
Yeah. I want to know which of the drugs is given to the newly born babies when before the breastfeeding begins. Which of them?
Okay, so we usually give them nevirapine.
Okay, thank you.
And usually what happens is that the mother is already diagnosed during pregnancy. So when she gives birth, it is known. And so it can be started immediately.
Okay, thank
Yeah.
you.
There was another question.
Doc, it was almost around the same question.
Okay.
That
All right.
there have been instances where children were brought to where I am, and they don't even take even 2 weeks, then they are gone. I don't know if it is because of the dosage or maybe the combination didn't work. So I had wanted to ask if the child is really sick and then the HB2 is low, which of the medication is the best for you to go with?
Okay, so if the HB is low, then you would have to avoid zidovudine, because zidovudine causes bone marrow suppression and will decrease the HB further. The thing with HIV is that if it is very advanced, you may have the child having complications. And so it is not advisable to start antiretrovirals when the child is sick and having other complications. It's best to treat those complications, get the patient well, and then you start antiretrovirals. I don't know if you are aware of something called IRIS. Because we are doing pharmacology and we are not treating HIV, I didn't really go into it, but IRIS is immune reconstitution syndrome, whereby the patient has a weakened immune system. You start antiretrovirals, and then the patient develops adverse reactions, very bad adverse reactions, because infections that initially were quiet, now the immune system is strengthened. So then the robust immune system leads to very bad adverse reactions. So we always say that starting antiretrovirals is not an emergency. You have to stabilize the patient first before you start the antiretrovirals.
Okay, thank you very much, doctor.
All right. So let's say this patient is very sick and needs transfusion and all that. You have to sort all those issues out before you go and start the zidovudine or the other medications that you want to give. Any other questions? Are we okay? We have less than a minute to go. Are we okay?
Yes, Doc.
All right. Okay. All right. Then I think on that note, we'll call it a day.
Doc, please, we'll be pleased to have your slides.
Yes. I think even with the antibiotics, I'm owing you.
Thank you.
Is Nick here? Okay, what do you have the antibiotics?
You sent us
Yeah,
antibiotics.
Yes, please. We have the antibiotics.
Antibiotics and then penicillin.
And then penicillin.
So you have all the antibiotics, all the 4.